Welcome everyone. It's 8 o'clock. Thank you so much for joining us today. There's so much going on and it's amazing to see so many people on our call today interested in talking about flu shots, flu season, schools, and more. I'm delighted I'm Dr. Tara Kieran. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine. And I'm really pleased to be co-hosting this session with the Ontario College of Family Physicians. And to that end, I'm going to just turn it over to Liz McGaw to give a bit of an introduction. Liz, of course, is our new president and delighted to have her here for the first time.
Thank you very much, Tara, and welcome everyone. We're delighted you're here. It's going to be a great morning. We have 4 panelists speaking today. As Tara said, very happy to be working on this community practice in partnership with the U of T Department of Family and Community Medicine. And there's some information there about main pro credits. The panelists will introduce themselves. So we'll just do next slide. Okay. So I'm just going to give the land acknowledgement. So we acknowledge that the land on which we are hosting this meeting is the traditional territory of many nations. We acknowledge that Ontario is home to many diverse First Nations, Inuit, and Métis people, and that each of you are joining us from one of those many traditional and treaty territories. We are grateful to be able to come together in this way.
And so, of course, the land acknowledgement is a great time for us to really reflect on injustices done to Indigenous people here in Canada in the past and in the present. And I think there's a lot to reflect on from recently. And I'm sharing these 2 articles actually from our faculty members that have helped me to reflect. Of course, so many of us were shocked by the treatment of Joyce Echaquan. And I think Janet Smiley and colleagues make the point that this was not an isolated incident, that racism is systemic and that kind of discrimination in hospitals and healthcare is what many Indigenous people face. And my colleagues, Suzanne Schusch, Nahid Dasani, and others spoke about the history of medical colonialism and how doctors were involved in residential schools and how as a profession we have a lot to own up to. So if you've missed these articles, please do check them out. We've been doing this now since April, and if you're interested in looking at past community practice sessions or interested in reviewing this webinar, they will be posted at that website, and we'll share it again in the chat. I just want to give a shout out to our planning committee. Our planning committee consists of a few people. Brian, you can go to the next slide, who helped to select the speakers. Next slide. We, of course, have a fantastic panel today, and we're really looking forward to the discussion. I'm going to turn it over to each of them in turn to introduce themselves and speak to their conflicts of interest. So, Jeff, I'm going to start with you.
Hi there. My name is Jeff Kwong. I'm a family doctor at Toronto Western Family Health Team. I'm also a senior scientist at ICES and scientist at Public Health Ontario. My interest is in influenza vaccines and other vaccine preventable diseases. And my conflicts, should I be talking about that right now, Tara?
Yeah, Brian, can you go to the next slide, please?
Okay, yeah, so I have salary support from ICES, Public Health Ontario, and the Department of Family and Community Medicine, and I have research grant support from CIHR, Health Canada, and the US CDC.
Thank you. Alan?
Morning, Alan Grill. I'm a family physician in Markham. I'm the lead physician of the Markham Family Health Team and the chief of family medicine at Markham Civil Hospital. My conflicts of interest, I've received some remuneration for talks I give at accredited medical conferences, all from organizations that are not for profit, and I do not have any relationship with the pharmaceutical industry.
Lisa?
Hi, everybody. Lisa Habermel here, a family doc who's currently up in Red Lake. I don't do any research, so I have no conflicts of interest related to research support and no other financial conflicts of interest that I'm aware of.
Thanks. Next slide, and then David, I think you're up.
You'd figure I figured out Zoom after I think this is the 7th one we're doing. I'm David Kaplan. I'm a family doctor at North York. Do comprehensive family medicine there, and I'm the chief of clinical quality in the now called the Clinical Institutes and Quality Programs branch at Ontario Health. And no conflicts, just support from the OCFP to be here this morning.
I'm Tara Kieran, as I mentioned, and I do a lot of research and have some salary support, and so I've listed some organizations I've gotten funds from, including one nonprofit, which is Gilead, who provided a grant money for a grant on hepatitis C. We're delighted to be joined by all of you. Of course, many of you are in the GTA, and we've done this deep dive to say so many of you are also coming from outside of the GTA, as far away, I think, as Kenora. So welcome. I wanted to, for those of you who are new, Brian, I wanted to let people know how they can participate. So if we go to the next slide here, we have there's two ways to participate. If you have a question, I urge you to put it into the Q&A box. Now, in a usual Zoom, we don't necessarily have a Q&A, but in this Zoom webinar, we do. So please put questions in the Q&A box. You can use a thumbs up signal. So if somebody else asked a question that you really want to prioritize, use the thumbs up, and then I know it's one that I'm going to make sure the panelists answer. If you have a comment, you want to actually respond to an audience member's question, you have a resource you want to share, then please include that in the chat. And it's helpful for us if the questions are in the Q&A and everything else is in the chat. So thanks in advance for that. So I'm delighted to get us going. We had so many of you registered today. I think we were actually maxed out at our registration at 500 today, which was a record for us. And I think, to me, that just illustrates how desperately family doctors want to come together to talk to each other about all the things that are going on. And in particular, I think flu season and flu shots is on everyone's mind. So all of you submitted questions when you registered, and we got a number related to flu season and flu shots. So I want to start actually by turning it over to you, Jeff. I mean, you're a flu epidemiologist, you practice family medicine. Can you give us some insight on what we can expect during flu season? And what are some of the answers to some of the common questions that we've been getting from family doctors about flu shots?
Yeah, yes, sure. Could I have the next slide, please, Brian? So 2 months ago, when I did this, I presented this, which is showing the weekly notifications of lab-confirmed influenza in Australia. And so that was back to August at that time. And we can see here in the red, this is the influenza during this season. What happened was it was going up until about March, and then the pandemic hit, and then it suddenly dropped to zero. And it's been basically zero all the way till October versus, so basically they're, most of the way through what usually would have been their influenza season, and they still have not seen any influenza, despite a reasonably large COVID outbreak centered around the Melbourne area, in the last couple of months, and which is now settled down. So this is reassuring that hopefully we'll see very little influenza activity. And can I have the next slide, please? This is just showing the influenza hospitalizations in the province, in the country, and once again, very little compared to previous seasons. So hopefully, if all goes well, we'll see very little influenza activity here. It'll all depend on how well we implement and maintain our other public health measures, and as well as people getting influenza vaccines. I heard that more people in Australia were getting influenza vaccines this year than in previous years. I don't know the exact numbers. And we are seeing, a surge in demand here, as we all know. But here in Ontario, we normally don't see influenza activity until early December at the very earliest, and it doesn't normally pick up until after the Christmas holidays. So there still is time, so you can reassure patients, you don't need to get your flu shots necessarily in October, for you to be protected against influenza. We don't see a lot of influenza activity at this time right now. Okay, so I'm going to ask you to go to the next slide, please, Brian. So symptoms of COVID versus cold and influenza. This is a slide I showed before, just to say that it's really kind of impossible to distinguish between COVID, influenza, and other respiratory viruses based on symptoms alone. You can see that there's a huge amount of overlap between symptoms, and this is a figure from Alberta Health Services. I'm going to ask you to go to the next slide, Brian. And since then, Public Health Ontario has put up a similar document, which has looked at a bunch of things, besides the symptoms and then severe complications. They compared here seasonal influenza, COVID, RSV, and rhinovirus. you can see a lot of overlap in the symptoms and a lot of overlap even in the serious outcomes. So, we do see patients in ICU with like, rhinovirus, for instance. Okay, I'm going to ask you to go to the next slide. So just quickly to, point you to the OMA's influenza quick reference guide. This is a really nice, handy, like 2-pager, which goes over everything you need to know about influenza vaccines for this season. So I think the first key point is that, patients who are 65 or older, we should offer them, like they should be prioritized to receive the high dose trivalent influenza vaccine if it's available. So if you have it, then you should be giving, they should, be getting that vaccine, the high dose vaccine. If you don't have any high dose vaccine in stock and they really want to get vaccinated, it is okay to give them any of the other vaccines. And the other ones would be this standard dose quadrivalent. The quadrivalent has 4 strains, the trivalent only has 3 strains. The high dose has 4 times the amount of antigen compared to the standard dose. And so it just outlines here also what equipment, what PPE we should be wearing when giving influenza vaccines. So just a medical mask and face shield would be indicated, and gloves are only needed if the skin of the vaccine recipient is not intact. And we should only be vaccinating those who have no symptoms. If they have any respiratory symptoms, they should just wait until they resolve before getting their influenza vaccine. Okay, next slide, please. So just a quick overview here by the age groups. You can see that for those 6 months to 8 years, we recommend that they get a quadrivalent vaccine, but only the egg-based vaccine is recommended in that age group. What's new this year is that there's a cell-based vaccine that we can give to those 9 years or older. That's also a quadrivalent inactivated vaccine. And then for those 65 or older, we recommend the high-dose trivalent. Other key points are that there's no flu mist this year, unfortunately, in the publicly funded program, but people can order it if you'd like from the pharmacy. You can buy it privately if you'd like. The high-dose vaccines are available at pharmacies this year, unlike in past years, and the pharmacists can vaccinate those aged 5 years or older. Okay, and next slide, please. And so just a reminder of the guidance from the National Advisory Committee on Immunization, or NACI, on some advice on how to have influenza clinics this year. So the key points here are to screen patients to make sure that they don't have symptoms when they're coming in to get their influenza vaccine, to employ physical distancing measures. So whether that's using appointments so they don't all come at the same time, having enough physical space in the clinic, doing the outdoors or drive-through, and we have Lisa here who's going to tell us more about her experiences doing those sorts of things. And I don't have a slide right here. Maybe we'll come to it later. But there's a program called myflushot.ca that I encourage all of you to check out. It's a way for you to register yourself as someone giving influenza vaccines, and it's a useful tool for your patients who are looking to get influenza vaccines. They're trying to get a repository of all influenza vaccine providers and have their vaccine inventory in place and allow for online booking. So it's a service that your patients can use and you can enroll for. So just go to check out myflushot.ca when you have a chance. Okay, that's it for me.
Jeff, thank you. So there's a lot of questions, and I'm going to ask a couple of them to you live here. I'm wondering, people are talking about who to give the high dose to. So immunocompromised patients under age 65, are those people who should be getting high dose or not? And what should a physician do if they're not getting enough high dose vaccine? So they've gotten 5 and they have 200 patients over 65. What should they be doing? What's your advice?
Yeah. So the high dose is only indicated for those 65 years or older. And we are supposed to prioritize it ideally for those with chronic conditions who are over 65. I think for those who are under 65 with chronic conditions, immunocompromised, I think that's a very good question. At this time, it's not recommended for those patients. But who knows, maybe in a year or two, that will be the recommendation and it will be publicly funded for them, but we don't know at this point. To answer your question about what to do if you don't have enough high dose, I mean, I think there are two options. You can either wait until you get more doses, which I think is reasonable. You know, it's still just mid-October. You know, we started earlier this year than usual. I think probably the best time to get vaccinated is probably November, because waning vaccine effectiveness is a real thing. So we don't know how long the vaccine, the protection from influenza vaccine, you know, will last. So, you know, getting vaccinated a little bit closer to when influenza activity is anticipated to start might not be a bad idea. So I think they can either wait, but if they really can't wait, then giving them, you know, a standard dose vaccine is perfectly acceptable as well. I mean, we have good evidence that the high dose is better, the high dose trivalent is better than the standard dose trivalent, but then the quadrivalent has another strain in there, and there's been no head-to-head studies comparing the high dose trivalent to the standard dose quadrivalent. So it might be actually, you know, the incremental gain from the high dose might be not as much.
Yeah, and then just to clarify, Jeff, FluMist is not available this year, and there's a couple of questions about that. Is that because it's, you know, not effective? You know, someone asked, does a physician have to administer FluMist if they buy it, or can a parent administer it without supervision? Do they need a prescription for FluMist? So actually, David, you said that you wanted to answer this question, so maybe I'll turn it to you.
Yeah, so well, it wasn't that I wanted to answer it, I just was going through them because you were answering it live, but go ahead.
Oh,
Jeff.
sorry, Jeff, okay. Jeff, go ahead.
Okay, yeah, no problem. Yeah, so I believe that a prescription is not required to purchase FluMist, that the patient can go to a pharmacy and purchase FluMist without a prescription. I don't know why it's not offered this year in the publicly funded program. Sometimes, yeah, so I don't know the answer to that question. I mean, it is effective. And, you know, there have been studies in the US showing it's been less effective compared to the injected vaccines, but there's conflicting evidence on that. And as for, I mean, me personally, you know, when it was being offered, I would actually give it to my own kids, but I'm not sure that it's appropriate to advise all of our patients to give it to their own kids. I mean, I think it'd be better if someone who was, you know, knew what they were doing was giving it.
So a couple of other follow-up questions to the high dose question that was asked. So Sid Feldman asked, do we know an actual number needed to immunize with the high dose trivalent to prevent one additional case of influenza compared to standard quadrivalent, i.e. what is the incremental gain? And I think that will help other people who are saying, you know, they find this very awkward, this discussion, to say to an older person, oh, I just don't have any high dose here. Do you want this less effective immunization?
So and I posted the link in the chat, but I'll post the actual link to the randomized clinical trial that Public Health Ontario used for its guidance. So we know that high dose TIV provides better protection than standard dose TIV against the influenza A H3N2 strain. And there's a large randomized clinical trial that shows that and I'll post that in the chat for anybody who's interested. I don't know if in the RCT it actually has a number needed to treat. We have to remember though that the RCT was not head-to-head against the QIV strain. And so we're sort of comparing apples to oranges, which is why I think we don't have the numbers. So the reason though that we give the high dose TIV is because in people over 65, and this is why we don't have the data for the immunocompromised, in people over 65, the burden of influenza A is much higher, in the H3N2 is much higher than the H1N1 A strain in influenza B. And we've known and Jeff probably has a data slide somewhere, but we know that with seasons with circulations of high influenza H3N2, many more outbreaks, more hospitalizations, and more deaths among old people. So the data is in people over 65, but it isn't a one-to-one. The large RCT wasn't against the QIV, which is what we're giving people instead of the TIV if we don't have it.
And just to add to that, David, so that trial, it showed a 25% relative reduction for high dose TIV compared to standard dose TIV. And my recollection is that the number needed to vaccinate to prevent a case of influenza from that study was 200. And with Sid's question is actually asking, high dose TIV versus standard dose quadrivalent. And so, like I said, there's no head-to-head study that's been done, but my guess would be that it would be a number that would be higher than 200 if you're comparing, because, the baseline would then be the standard dose quadrivalent rather than the standard dose trivalent. I hope that answers Sid's question.
Thank you, Jeff. So you mentioned myflushot.ca, so we've put that slide up here. And so please do check out that resource and do participate and put your information in. I'm gonna, there's been a lot of questions. There's still more questions on the Q&A, and I think, Jeff, you can probably start to answer some of them through typing, but I also just wanted to draw attention. I think you mentioned that when you're giving a flu shot, you only need gloves if the patient's skin is broken. I believe it's either party's skin is broken that you
Sure, that's right.
So I'm just going to clarify that point that was clarified by one of the audience members. What I'm going to do now is actually turn it over, though, to Lisa. So I wonder, Brian, if we could go to slide 20. So there's been a lot of questions in the chat already, about the logistics of how do we manage this. And I see people already saying, we're using online booking or phone scheduling. We're not doing walk-ins. How are you doing the screening form? Are you doing that like on remotely or on paper? So there's lots of logistics to manage. And I think one of the unique forms of delivering flu vaccine this year have been the advent of these drive-in walk-in flu shot clinics. And I saw this tweet on my Twitter feed from Lisa Habermill, and it was clear that she was doing this up in Red Lake and was starting to get some great experience. And so we're delighted to actually have Lisa here today to speak to her experience and the community's experience doing drive-up flu shot clinics.
Great. Well, thanks very much. We now have 3 sessions under our belt, so I don't know that that qualifies me as an expert by any stretch, but we've got lots of lived experience. For a little bit of context, just so everybody knows, Red Lake's a community of just shy of 5,000 people, probably. We're at the end of the highway where we have one stoplight, so we're quite isolated, and our patients are all almost in the only clinic's EMR. So we do have some advantages in terms of primary care that way. So that might be different, but a lot of these tips I think will apply no matter what. We started planning about a week prior to this. We realized we probably should get thinking about it. We churned over, do we use our COVID carport to do it? Do we do in person? And we landed on, because we're adventurous and so are our patients, we decided that the parking lot mechanism was the best option for us to at least give a try to. Weather obviously provided a bit of unpredictability for us, but and also not knowing whether people would adapt. So those were kind of the 2 challenges that we were worried about. The weather we sailed through, and the patients signed up like crazy, like hotcakes. What we decided was to try and book in 2 streams. So we had team A was an injector and an administrator, or administration person. Team B was the same thing, administration person plus an injector. And then we had a traffic director, 1 or 2 of those people. So we decided each stream we would put in a 45-minute block. The first 15 minutes was going to be the injections. The second was the observation period, because try as I might, I could not convince myself that we could do less than a 15-minute observation period because of the risk of syncope and driving. And then the third 15 minutes of that 45-minute block were for redrawing, warming up, managing anything that might come up. And we did stagger the 2 teams by 15 minutes. So team 1 might start at 1 o'clock. So they're doing injections at 1, and team B then started at 1:15. First day, we decided that we would put about 8 patients per 45-minute block to give us room. Next day, we ended up doing 10 patients. And quite by serendipity, on the 3rd day, which was yesterday, we ended up only having 1 injector. So we actually did a rocket rounds of flu vaccine, and one team of us did essentially 1.5 lines worth of work. And so what we probably can actually do is look at a 45-minute cycle as a 45-minute cycle, and we did we had one 45-minute cycle where we ran 18 patients through with great success, and probably actually had a little more room available than that if we pushed. We advertised on Facebook because that's how you do it up here. And they filled up, the spots filled up within we had the clinic booked 24 hours later, and it was full within about 6 hours. When people phoned, we actually set aside a cell phone we happen to have that we said, call this number, so that it wasn't conflicting with our clinic lines. Although some people did book through the clinic lines. So they were asked when they were booking, have they ever had a flu shot before, and any reactions? That in that case, we probably wouldn't do it at car side. First shots we decided we would do at the car because I thought it was more important to get the shots in. We told them to come 15 minutes early as we sort of maneuvered how to make traffic flow happen, and everybody did. We asked everybody to wear t-shirts. Not a single person didn't wear a t-shirt. It was fabulous. They were asked to wear a mask, and they were asked to do the COVID screen online before they came, and not to attend if they failed the screen, and then to call our COVID line, which is the other cell phone. So that worked really well. Staff had no particular issues, and people were excited to book. On the day of, what we do is print the billing sheet in the morning, and we run on Practice Solutions, or PS Suite, whatever it's called these days, and printed out a billing sheet so we could see age. We highlighted all of the 65 and older, so we knew how many were going to be a high dose. We were very fortunate so far to have enough vaccine to do all this. And counted those up in our block, so we knew what to draw with each. Flagged any kids or really tiny elderly people who might need a 5/8 inch needle, but everybody else we drew up as a 1 inch. And we were fortunate because our regular vaccine all has the same expiry date and lot number, so we didn't bother logging that because they're all the same. So we'll retroactively input that. We did our trays up. There's a photo, I think, on one of the slides of our tray. A few tips I would pass on. So please make sure you have a garbage bag. And if there's any chance it might be windy, please weight your garbage bag with some stuff in it, because otherwise it just blows away. Same for your sharps container. I would not advise taking an empty sharps container because the wind, they act like a sail. We opted to use cotton balls and tape instead of bandages because it was much more efficient in terms of time. You're not having to open things up and be sticky. I finally figured out on day 3, your best option is to try and get a nice liquidy hand sanitizer, because the stuff with the gel actually collects on your hands. And once you've done 3 or 4 rounds of sanitizing between patients, everything sticks to your hands. So that stuff that smells like vodka, that's the stuff. And of course, having your rescue meds ready. We had decided I would just carry it in my pocket. Everybody knew I had it. So as long as I didn't fall down on the pocket containing the rescue medications, we knew we were going to be okay. It's worth mentioning we are physically close to our clinic and our vaccine fridge and all of our emergency equipment, so I could run inside fairly quickly and grab oxygen. And we are equidistant from the hospital, so depending on what the response was, we could take the patient one of 2 ways. At the car side, the administration person had the list with us, and she would confirm the name. We did not check health cards. We thought if they knew a name and they were on, I was happy to give them a flu shot. They also assisted the injector with the cotton balls and tape. My job as the person giving the shots, I quickly asked if anybody had any symptoms of COVID. And in addition to the not injecting people with respiratory symptoms, our main thought was that if somebody had a reaction that we needed to deal with, to have somebody who might be COVID positive and us be interacting would really throw a wrench into the rest of the day. So that was actually our main thought in screening for COVID, not just the symptoms piece. Did a quick consent. I'm a stickler about consent, so they all got consented, and made sure they were okay to wait for the 15 minutes after the shot. And they were asked to honk if they had a problem, if they felt in any way strange. And we did keep a closer eye on people who were by themselves or if they were a first-time injection. Documentation was great. It was a check mark. Oh, I'm hitting the time.
Oh no, I'm just like, I'm seeing lots of questions coming in, so I want to also make time to answer them as well. But keep going, Lisa.
A couple more little tips. On your billing sheet, right or left, like RL, and the admin person circles it, and you have your documentation, what you need completed. And I'll give you 5 tips. Your weather's unpredictable, leave a block in for warming your staff up. If you can, stagger your cars with one space in between so that your cart can move and there's a little bit of privacy allowed. It's really helpful if a whole household is in the vehicle because you only have to consent once. Inject your driver first because their 15-minute clock starts. And then, to be honest, if everybody else has had the vaccine before, I'm content if they just wait 10, but the driver's 15. And use who you've got. We had dietitian, social worker helping us out because our nurses are completely burnt out from COVID. So we decided to give them a break, and the docs and some of the hospital nurses did the injections. And that's all. It was great and it's fun.
Thank you, Lisa. I mean, I think it was great to kind of hear about it in action and your very practical tips for how to make that work. Obviously, your setting is going to be different than many other people's setting, which can make it difficult to maybe translate this. But I think for some people, I can imagine them doing something very similar, even in a suburban parking lot, et cetera. So near the clinics. So thank you. Some of the things I did want to get to is there are some questions sort of about this wait time afterwards. And I think there've been some good chat here with both Jeff and Barry kind of saying that the risk of anaphylaxis is like 1 in 1.5 million, 1 per 1.5 million doses. So it's really tiny. And then some questions about, how long we need to wait after. And Alan, I think you wanted to speak to that.
Yeah, no, there was some great stuff in the chat. Just really quickly, I mean, the way we're doing it in our office is if you've never had a flu shot before, we actually do a 15-minute waiting period, and we have a couple spaces that we've put aside to put patients so that there's so physical distancing is respected. Otherwise, we usually tell people, to wait 5 minutes, and then they kind of walk out the door. In the drive-through clinics, if you have a big parking lot, and I think Lisa spoke to this, and people can actually wait in their car for 15 minutes, and there's enough room, it's always advisable to wait longer. And as Barry said, because of the risk of anaphylaxis is so low, this whole 15-minute window is changing. We'll share a document from New Zealand. They actually changed their recommendations and they gave guidance. So they said, if you're with a child and the child's with an adult and the adult can monitor them or knows how to seek emergency services, you actually don't have to wait 15 minutes. You can probably let them go after 5. So things are changing. We'll share the document, and great chat.
Yeah, so that document is actually on the Center for Effective Practice website. So actually, if we go to slide 23, Brian, I'll just put up the Center for Effective Practice website information there, because I think people may, if you haven't checked out that tool, I think it's worth checking out. And I understand it will actually be updated with a lot more practical information, even more practical information added early next week, but it does have actually that New Zealand guidance embedded in there. Now, of course, be mindful it's from New Zealand. I think the other thing that I wanted to ask, some people were asking about the cold chain, and that their public health unit has expressed concern over the cold chain, the drive-through food clinic cold chain. And I don't know, Lisa, if you wanted to speak to that, if you had a chat with your public health unit.
So I did, and got much of the same message. But the reality is, as a clinician, we sort of had to make a decision about risk-benefit, optimizing the number of people that we're vaccinating. It also helps that it was between 2 and 8 degrees outside. So I scrolled through as many documents trying to look for evidence about how far in advance can you draw. Our preloaded high dose comes in a glass vial. So attaching a needle and putting it back in the fridge till we use it, intuitively, it doesn't make sense to me as an individual that would change the efficacy in any way. But our vaccine fridge is close, and we would come in each time to take vaccine out. We did draw up to, I believe, up to an hour and a half in advance on our really, really busy day with the 1 injection stream. And that was a clinical decision that I made actually as the whole team. And again, we did keep it cold in between. So they were drawn up and back in the fridge. But yes, if you live up here where the temperature literally was between 2 and 8. In fact, yesterday I joked because it was 0 degrees, I think. And I thought, geez, wouldn't that be funny if my vaccine freezes in the meanwhile?
Thank you.
So I'd be happy to hear from the experts on that if they've got any feedback.
I mean, I think at the end of the day, what you're describing is a pragmatic approach. And I think what Liz McGuh also spoke to is that there is variability by public health unit. So in Ottawa, it seems the public health unit actually provided cooler bags to a clinic doing a drive-through vaccine. And there's a link that I shared on the chat from Liz, actually. This was Liz's text that I just put in the chat as well, just so people, in case they miss it. Liz, did you want to speak to that at all? And I know you've also had some comments about Ottawa helping family doctors with their flu clinics, and wondered if you wanted to share those too.
Yeah, I guess, I mean, maybe just to say that, you know, one of the issues in the province with vaccination for the flu every year is that we're dealing with 35 different local public health units and different ways of doing things. So Ottawa, what I shared was, it's actually an article, a short little piece that a clinic in Ottawa published in the CFP journal about a clinic that they were actually doing this summer, where it's not as cold as it was right now up in Red Lake. But so they talk a little bit about the cold chain, and the public health unit supported them in terms of providing bags and assistance on maintaining, you know, the whole cold chain. And, you know, I think some units, Ottawa's actually providing space for, they're doing large community clinics at 3 different sites across the city that'll be open to everybody in the public, but they've also partnered with about 40 practices in Ottawa to supply space for family doctors to bring their patients in at that time. So public health gives a space, helps with screening, provides the vaccine, and family doctors can show up with their, you know, with Wi-Fi connection and send their staff and do the vaccinations that way. So, you know, I think part of what we're seeing, as we said, is sort of the challenges across the province and the opportunities across the province to do this.
Yeah. If you go to the previous slide there, Brian, I just wanted to share this next resource around drive-through clinics in case you haven't seen it. So this is something from the CDC, the American CDC, that may be helpful to folks as well. Also, you know, people are reminding us that, of course, we need to also be opportunistic and provide flu shots when people are there for their appointments. And we know we're seeing many of our high, you know, people who we might be more worried about in the clinic. As it is, and others talking about how they're leaving the door open in their clinic. I wonder if any of the other panelists want to share kind of how they are approaching flu shots in their clinic. I know drive-throughs may be helpful for some folks, but it also may be difficult for others. Like, so I'll share in my own clinic, we work downtown and there are no parking lots for our clinics, unfortunately. And so we also worry about crowding in our waiting room during our if we did a flu clinic in addition to our regular clinics. So we have 6 clinics, and the clinic I work at is 14 doctors in that clinic. And so we, as it is, are spacing out our clinics to try not to overwhelm the waiting room. And so for the most part, we have some dedicated weekend and evening clinics that we're going to be doing. And the weekend clinics will actually be in a separate location from our usual weekend clinics. And we're going to rely a lot on some physician volunteers to come in on those days. We're also going to be trying to add in some dedicated flu shot, you know, the days we have low volumes in our clinic, some dedicated flu shot clinicians who are going to come in to just do the flu shot. So that's how we're trying to get around it. I'm going to turn it over. I think, was it David that you wanted to say something?
Yeah, I was just going to say, so we used online booking. Actually, we sent out our email last night once we could confirm we were going to have enough vaccine just to start with our under 5 clinic. So we've invited all families with children under 5 to a special clinic. And we actually created a separate schedule in our EMR. And what we did was, because it was sort of, we had to figure out an average kind of volume, we basically broke up an hour into 10-minute blocks, and families could pick a block of 10 minutes. It was actually quite interesting, because I would say probably within about an hour and a half to 2 hours after sending out the email, that whole clinic was full. So I think the uptake of the vaccine is likely going to be pretty high this year, which is probably why we're hearing a lot of anxiety from our patients, which is great messaging from Jeff early on about peak flu season and not needing to get your vaccine today. I think the other thing is really, it's hard if you don't have the physical space even to wait the 5 minutes and not congregate. So I think, one of the things that is helpful to do is to map out your space on a piece of paper, and just try to figure out how you can safely see people. I know some medical buildings, some of the tenants, at least in Toronto, have been told that they can't use hallways this year because of COVID to sort of line people up or space them out. So I think you need to sit down with you and your staff and a piece of paper and just physically figure out how to do this. I also think the real advice, and this is, what I've taken to heart, is if you're going to run clinics, they should be, small and frequent again. So you don't want to have, huge lineups of people. Try to do online booking or telephone booking ahead of time if possible. So those are kind of the general principles we've chosen.
Thank you. So, I know there's lots of questions still about flu and flu shots, and we've got some people sharing their best practices on the chat. I wanted to take the conversation though in a slightly different direction right now, and also just talk about this, the fact that over the next little while, I think many of us are expecting, and we've already started to see a lot of people coming in with URI symptoms that may or may not be COVID. And I know many of us are kind of worried about how are we going to manage that influx. So Brian, actually, you can stop the slide because I'm going to turn it over to Alan, because Alan, you've been doing some interesting work in Markham, setting up a respiratory assessment center there. So that's sort of an innovative way in which I think your community has come together to say we want to have a way in which we can deal with respiratory illness safely and allows our offices to still run efficiently while still meeting patient needs. So I'm going to turn it over to you to maybe speak a little bit on that.
Yeah, for sure. Thanks so much. So we started our assessment center at Markham Stouffville Hospital, which is a partnership with the Eastern New York region, North Durham, Ontario Health Team. We started our assessment center early in wave 1, and our center actually has always examined patients if they came in symptomatically and they needed to see someone. So it was a little bit different than some of the other assessment centers that you went to if you just needed a swab and then you sort of went back. So we decided to do this for the exact reasons you mentioned. We wanted to make sure that patients had definitely had a place to go, and the emergency physicians and the family physicians in the community got together and said, we're gonna work the clinic so that so patients can come. It's a safe space. We've got the PPE. It's very efficient. There's a nurse that does the swab, and that will also take some pressure off of family doctors so that they can see patients with other chronic illnesses, et cetera, et cetera. The other goal was obviously to prevent too much overflow in the emergency room. Like, we don't want to breach the surge capacity in the emerge. So we opened up that way. Right now, as of literally 2 days ago, we've expanded the assessment center indoors. So we had it in a trailer outside. It's now indoors. There's 10 examination bays. Right now, there's 2 physicians per day, 1 for each shift. We are expecting to see up to 400 people a day. We could go up to 600. There is sometimes a limit with the number of swabs you can do, and the ministry gives you instructions about that. But if we have to go to 2 physicians per shift, we will. My understanding, it works very well. Patients have to register in advance. So obviously there's no walk-ins. They usually get an appointment that day or the next day so far. And the other thing I want to mention is they get a discharge form when they leave. So the other key thing is that when patients go and they get assessed and they get a COVID test, some of these patients won't get better even if their COVID is negative. They still need somewhere to follow up. And so the family physicians, there's a discharge form they get on what to do afterwards. And part of that advice is to contact your family physician. And we'll go over, I think, in a bit on some advice on how you manage those patients afterwards. But the community came together so that there was a place to do it. And I can tell you that there's other places in Ontario that have done this. It's not just unique to Markham. I know that in North Durham, the Port Perry family docs and the Uxbridge family docs got together and set up a similar clinic in a building that wasn't being used, and it's been very successful, and it's totally primary care driven. So that's my quick story about that.
Thanks, Alan. I'm going to touch on a few questions that are still popping up about the flu shot, so I think it's worth just highlighting a few things that are coming in from the chat. So, I think people are saying, some of the patients are getting upset that they aren't able to meet the volume of demand that there is. And I think just a couple of things I want to reiterate. One is Jeff's talked about early on that, it's okay if people get their flu shot well into November. Often we're not seeing flu until early December. So that's, something to reassure your patients. It doesn't all have to happen now. I think the other pragmatic thing is that many of us, so I mentioned our own clinic, and I think Jeff has talked about his clinic as well, is we're really prioritizing the people who can't be seen at a pharmacy. And so those are kids under 5. I think it's reasonable to say to patients, do you want to, try and get the flu shot from your pharmacy or your public health unit? Because not all of us do have waiting rooms or parking lots where we can accommodate, or the staff where we can accommodate giving all the flu shots. So I think it's reasonable to say, please, try these other avenues, and we're prioritizing those people who can't get it from a pharmacy. So we're prioritizing people, basically kids under 5. So those are a couple of things that I just wanted to draw out from the chat that I think have recurred. There continue to be some questions about the wait time post-vaccine. So just to reiterate, the technical guidance is 15, but New Zealand says is less than, New Zealand has guidance of less than 5. And if you check out New Zealand has guidance for 5. And if you check out their Center for Effective Practice website, there's more details there. Okay, so I think, I'm turning it back to you, Alan. You were talking, about respiratory assessment centers, and how even after someone gets seen in a respiratory assessment center, it's going to be potentially tricky to manage them if the symptoms continue. And I think one of the things we've heard from folks as well is just how tricky it is to figure out whether, when we're seeing someone virtually, can we go ahead and just treat it as a viral illness? Should we be prescribing antibiotics? And I think many of us are worried that we're prescribing antibiotics too much. And so I know wanted to speak to a new resource that's come out from Choosing Wisely. So I'm going to just turn it over to you. And Brian, I wonder if we can go to slide 29.
Yeah, thanks so much, Tara. So as those slides are coming up, there was a partnership between the College of Family Physicians of Canada and Choosing Wisely Canada in 2019. I've given the link here. And basically the campaign was all about trying to reduce unnecessary antibiotic use in patients that were presenting with respiratory tract infections, most of which are probably viral most seasons. If we just go to the next slide. Some of the barriers that we already knew about were things like, I think it's quicker to just hand a prescription, or the patient wants the prescription. They want kind of like the loot bag when they leave the office. And there's some evidence to show that that's actually not necessarily true. And it's actually better if we take the time to discuss with the patient whether they need antibiotics to reduce risks of things like adverse side effects, the cost to the patient, and all these drug-resistant infections that seem to keep popping up. During the pandemic, it's gotten even more difficult because we've shifted to virtual care. So we're probably seeing less patients overall in our office. And so we're dealing with RTI symptoms over the phone. PPE at one point was a challenge. I think is less of a challenge now in order to see patients. And in some situations, even if you have PPE, your office may not be swabbing a patient for COVID. So when someone presents with RTI symptoms, probably the first question you're going to ask is, do they need a COVID test? And if they need a COVID test, you're probably going to send them to an assessment center, because that's what the province has sort of been asking us to do. But then you're stuck with the situation, well, if that test comes back negative, and what if it's pneumonia? Do I just give them an antibiotic? And so that's been another challenge. And also, what happens if patients who test negative for COVID are still sick? Like, someone has to see them. So if we go to the next slide, what Choosing Wisely did was they took the cold standard, and yes, it's sort of a play on the word of the gold standard, module that came from the original campaign, and they adjusted it for COVID-19 pandemic. And if we go to the next slide, and I'll put the links in the deck. There's also going to be a webinar on this next week, so I'm going to do this really quick. But basically, here's an algorithm, and just in a nutshell, what it's saying is the first interaction with the patient is usually virtual, which is at the top. And you really have to ask yourself 3 questions when they're presenting with an RTI. So do they need a COVID test? Most of the time, the answer is yes. And then you have to figure out where they're going to get that test. But on top of that, you have to ask yourself, can I manage this patient virtually? Like, if the COVID's negative, like, can I manage them virtually and follow up? Or do they really need to be seen? And sometimes being seen does not correlate with getting swabbed. It does in Markham, but it doesn't everywhere else. And so what we did was we created a list of different RTIs, and we gave advice on what you can ask over the phone in the initial call that will steer you towards, yes, I can manage this person virtually, or no, I really should bring them in. And then in both arms of the algorithm, you still have to ask yourself, do they need antibiotics? And in some situations, you can give a delayed prescription. And in other situations, you can give them an actual prescription. And if you go to the next slide, and I'm not going to go through this entire thing, but you'll notice on the right, we have the conditions listed, and we have questions you can ask virtually when you start off, and then certain answers you get that will lead you towards an in-person visit. And so choosing wisely just set this up, because so far we've all been struggling with how much can I do virtual? How much can I do in person? Can I give an antibiotic if I'm not seeing them in person? And the answer in some situations is yes. And so I would encourage you to check out the tool. I'll put the link for the webinar I'm doing with Jerome Lease, who's an ID doc at Sunnybrook, next week. And you'll have a week to digest it, and then we can answer any other questions on this later on. The next two slides aren't that important to show.
Yeah, thanks, Brian. I think you can end slides. So thanks, Alan. You know, I think people are saying thank you for that kit, because I think it's going to be really practical for folks. I think people are also really impressed by the Respiratory Assessment Center. People mentioned that there are other ones out there, and I think Lisa, for example, mentioned that there's one where up in Red Lake that they've organized. I think there's a couple questions though I want to throw out to you. Somebody asked if you are doing strep swabs at the Respiratory Assessment Center in Markham. And then, so that was Claire Murphy. And then Nadine Lariah asked, how is the Respiratory Assessment Center in Markham funded? What's the funding infrastructure and non-medical staff? So I think that's been one of the barriers to setting these up elsewhere.
Yeah, great question. So I won't get into all the politics behind it, but our hospital doesn't do rapid strep tests. So in the and I won't get into why that's the case, but in the assessment center, they are doing charcoal swabs. So again, and you'll read this in the Choosing Wisely tool, if you think someone has strep based on, usually it's the center score that you use, and you swab them, you can actually give them either a delayed prescription while you wait for the result to come back, or you can actually treat right then and there, and then you can stop the prescription if the result is negative. So it's really your comfort level. There's sort of two schools of thought. Rapid strep tests are obviously better, and if you can use them, I highly recommend them. In terms of the funding, it's a great question. So Ontario Health did give us permission to be an assessment center, which actually allowed us to build those H codes, which helps with some of the negations that happen with the various ways we bill in Ontario as family physicians. The hospital has had to put in some of its own money for renovations, and I think they use the foundation. So the hospital really stepped up, and I have to give credit to my hospital. They've been very understanding about primary care needs, and I've tried to share that with a local planning group that David Kaplan and I both sit on in Central Region. And so we're hoping that our model can be duplicated elsewhere. And as you've seen in the chat, I think it's already been duplicated. But yeah, that's how we funded it. We had to use some of our own funding.
Thank you. We have, Alan, there have also been some requests for the webinar link. So hopefully you can send
I'm going to do it right now.
Perfect. And I'm going to turn it over to you, David, because there's also been some questions just about other vaccines, and particularly the grade 7, 8 vaccines. And I think you wanted to speak to that.
Yeah, so, as many of you know, public health administers a series of vaccines to kids in grade 7 and 8. And this year, for a variety of reasons, both logistical in the school, redeployment of public health staff and public health units to support contact tracing and flu shot clinics, they've elected not to do that. I think, there's a lot of discussion about the fact that they elected to not do that without speaking to primary care first. And I think a lot of us are worried about, getting these kids immunized. I do think that just generally, yes, it's important to immunize these kids, obviously, with Gardasil and hepatitis B vaccination. But I think we also have to think about the marathon that's ahead of us in the next couple of months, dealing with patients with respiratory illness, with COVID, with hopefully a COVID vaccination. And in the scale of priorities, yeah, absolutely, these things are very important. But if they're delayed by a couple of months or by a year, I'm not sure it's going to be necessarily the end of the world. Obviously, in parents who want to have their kids get Twinrix, you know, I know they come into my office anyway, and they don't get hepatitis B vaccination in school. But I think we have to focus our energies. You know, we're all running, I think, as primary care now, like full out. And we should really focus our energies on the task ahead of us, not losing sight of the fact that we have this catch up to do, but it's only one in a series of many things that we're gonna have to play catch up with. And hopefully we'll figure this out with our public health partners. But there are multiple different, as Liz said earlier, you know, multiple different public health units in the province. And I think what we do need to do is figure out how to do this provincially and not have it up to every individual public health unit, how we're gonna play catch up. So definitely heard provincially, and we'll take it back to the provincial primary care table that Dr. David Price chairs.
Thanks, David. So just a reminder to everyone that we are going to be posting the webinar recording along with the resources, and all attendees will also get a handout with all of the resources that we've shared on the chat today. So fear not if you haven't been able to keep up with that volume of stuff going back and forth. Shout out to Brian Aw, who also mentioned that in Richmond Hill, Mac Health is running a COVID flu clinic as well, and he's shared the details. Maybe I'll post that in the chat so people can see it. I do wanted to also reiterate, you know, that I see from a lot of the chat that people are finding it really difficult because their patients, you know, there's an expectation from their patients around what it is that you know, the patients want it, the flu shot. They're hearing that it's important to get it and they want it now. So just to reiterate that, you know, in fact, I think Jeff and Kimberly Wintemute and others have been reminding us that, in fact, there may be benefit to getting the flu shot sometime in November or later, because flu vaccine effectiveness does wane over time. And so, of course, please, we are going to need all of that ramp up time, and reassure patients that we will continue to get supply and we will be able to eventually meet their demand. So I know it is distressing, but I know we're all doing our best. I do want to just take a moment to ask folks if they have any recommended topics for next session, to please put them in the chat for us. So we want to know which speakers you might want to hear from, what topics you might want to discuss. So please put those recommendations into the chat. Actually, before we go to the end there, Brian, I want to spend just the last 2 minutes with we didn't get to this, but David, I know there have been a lot of questions about back to school, and particularly changing in the school screening and testing guidance. And so, Brian, I wonder if you could just pull up the website from the Center for Effective Practice Schools. And Brian and David, maybe you could just speak briefly to this resource that might be able to practically help folks.
Yeah, for sure. Thanks a lot. And I think one of the things that I wanted to speak to, and I got clarity ahead of the webinar. I know there's a lot of questions both in the media and from our colleagues around where the guidance came to make some of the changes to pediatric testing. And I did get confirmation from the folks in the Chief Medical Officer of Health's division in the Ministry of Health that Public Health Ontario, which is like our version of the CDC or the BC CDC, actually did an independent review of the literature to advise the ministry. So this was actually, the literature review for this was actually done outside of the Ministry of Health and an arm's length agency, which I think a lot of us wanted to hear. Not obviously messaged that well to the public, but or to us, but I was able to get that. So if you went back to that website, so a group of us, family medicine, sick kids, public health unit, and the chief medical officers.
Brian, can you go back to that website? Thank you.
Developed an algorithm to help clinicians. So this is not meant for parents, to help clinicians work through the symptomatic child to decide whether or not they need to have a test or not. It's an interactive tool, and you can find it on the center. The folks at the Center for Effective Practice were really helpful in taking that flat algorithm that we designed and creating an interactive tool, and it gives us a bit of guidance. In fact, your front staff could use it on the phone with a parent or guardian with a sick child, and it should just be able to offload some of the cognitive load on physicians and nurse practitioners.
Thank you. So, Brian, I think we will end up going to the last slide. I guess the last thing I'll say is I think Alan Grill sent really, you know, an interesting article link about schools as we were discussing this issue, and I'm just going to share it here in the chat because I think it's a great article that you know, talks a little bit about the evidence, and I know some of and the rationale, and I think you know, as I think Alan, you said, some of the bottom line is you know, we probably do, though, as clinicians, have a low threshold to test, and at the same time need to be mindful of community case counts, which are rising. So maybe more about that at our next community practice session. I know this one was really full of questions about flu shots and flu season, and I hope you found the information useful. Again, the webinar recording and resources will be available on our website post-session, and we will be emailing out to you the list of resources, and you should be getting your Main Pro credits certificate in over email in the next week or two. We will be having another community practice session in November. Please fill out our evaluation and tell us what you want to talk about at that community practice sessions. We design these sessions around your needs and your suggestions. I do want to just thank all of the folks behind the scenes who helped make this happen. Our fantastic planning team of you know, Leanne Clark, Susan Taylor, Mina Viscardi Johnson, Trish O'Brien, and then also Brian Silva, who is absolutely invaluable with his technical expertise. And then, of course, a huge thank you to our panelists who contributed their time and expertise today, and to all of you for also sharing your wisdom on the chat box. So thank you and stay safe. We'll see you again in November.